So I'll be speaking on high-risk coronary artery plaques in asymptomatic patients with type 2 diabetes mellitus. Okay. So all our present understanding in the cardiovascular events is centered around the atherosclerotic plaque and the process that leads to acute plaque rupture. Atherosclerosis is characterized by lipid deposition, LDL with arterial intima. How it forms the atheromatous plaques represents a nidus for inflammation. This lipid becomes oxidized, triggers an inflammatory response considering of macrophages. These macrophages engulf lipid particles to form foam cell. These pro-inflammatory cellular phenotype promote ongoing inflammation, then acute plaque formation, then the rupture. Diabetes mellitus is always associated with role of CV imaging, cardiovascular imaging in symptomatic patients with diabetes mellitus and in asymptomatic patients with diabetes mellitus. So what diabetes mellitus causes in heart? So it changes the cardiac structure and function, means LV systolic as well as diastolic. It produces silent myocardial ischemia. It produces heart failure. It produces autonomic dysfunction and then endothelial dysfunction leading to atherosclerosis, formation of calcium, then atheromatous plaque formation. So what imaging can offer? Imaging can provide assessment of luminal stenosis, plaque burden, plaque characteristics, disease activity and ischemia about silent coronary atherosclerosis. So there are so many advances in imaging offers the potential to identify individuals at high risk of myocardial infarction, the vulnerable patients. These individuals might then be targeted with aggressive therapy if you can detect the high risk atheromatous plaque to prevent future events. The next challenge is to demonstrate that these techniques can have a beneficial role as per the cost-effective fact even in the form of cardiovascular outcomes. So what are the characteristics of an unstable rupture plaque? As Dr. Jadhav has already mentioned the different characteristics, but I will talk about the characteristics of unstable plaque from the nuclear imaging points. So there will be extensive inflammation, a large necrotic core, a thin fibrous cap in inflamed lesions. This cap becomes slowly thinned out and weakened by the action of matrix metalloproteinase, predisposing to rupture. So the rupture occurs, then positive remodeling with a large plaque volume, that is also a sign for rupture. Then comes the microcalcification. Then comes the neovascularization in atherosclerotic lesion. So these are the characteristics of the findings where you can say this is an unstable plaque, unstable culprit plaque. So how the culprit vulnerable plaque looks? So there is a inflammation, then in the below, there is a big, large necrotic area in yellow color. So there are small black area that has spotty calcification, and there is an inflammation area, there is a thin fibrous cap, then there is a remodeling and neoangiogenesis. So this is the difference between histologically how a unstable plaque looks as compared to stable. On the left-hand side of your screen, that is called a stable plaque. But in the right-hand side, this is a unstable plaque, which can rupture at any time. So who are the patients to be benefited? These are acute coronary syndrome patients, asymptomatic, type 2, silent, diabetes mellitus, doing very well without any much symptoms, but with or without sugar control. Then acute coronary syndrome in MI group. Then continuous chest pain the patient is having, lasted for more than 30 minutes. Left bundle branch blocked, elevated cardiac markers also there, chronic stable angina, then abnormal myocardial perfusion scintigraphy, what Dr. Prabhu had presented for myocardial ischemia, detection of silent myocardial ischemia. So what are the exclusion criteria? Patient with pregnancy, history of allergy to iodinated compound materials, renal dysfunction more than 1.5 mg, inability to hold breath and follow instruction while performing the scan, patients with hemodynamically unstable patients. What are the armory of radio tracers available? So it facilitates the imaging of these atherosclerotic aspects of atherogenesis and plaque destabilization. It labels in the following ways. How? The macrophage mediated inflammatory change. Hypoxia resulted inside the inflammation. Then inflammation within the atheroma can promote causing microcalcification. So do you know what is the size of this microcalcification? Deposition of calcium smaller than 50 cubic micron. So these are the findings predisposed to rupture either through a mechanical dispersion to the fibrous cap or as a result of inflammation producing thrombosis and producing MI or producing cerebral infarction. So what are the PET tracers available? As you know, 18F Fdg used very rampantly, very efficiently in all oncology patients. So we started with 18F Fdg. Then comes the very potent agent, 18F sodium chloride. This is a bone-seeking agent, bone scan agent. Then gallium-68 dotatate. Then copper-64 dotatate. The comparison is it has got a longer half-life of 12.7 hours versus 68 minutes of short half-life. So that will help to organize our patient. Then C11PK 1115, then 18F fluorine, then hypoxic agent 18F fluoromisinazole, then 18F RGD, then gallium-68 nota, and then gallium-68 pentaxipar, which is coming very well. So this is the schematic diagram where the various radioisotopes tag with the macrophage, tag with the microcalcification, tag with so many other aspects. So this is the schematic diagram of the PET tracers. So as you know, I will not tell much detail. 18 fluoro-DFC, it accumulates in atheromatous plaque very well and all, but it does not have any application. But it does not have any role with microcalcification. But this uptake is obscured by the huge uptake of the myocardium. But if you do the suppression, you can look at the but this is not very specific for atheromatous plaque. So you can see here the example, the descending aorta, the agents, and there are so many areas of increased uptake. These are called atherosclerotic plaque in big arteries like aorta, carotid arteries. So all these arteries are showing the increased uptake of FDG. So here, when you inject the FDG, we have to wait 60 minutes, 120 minutes, 128 minutes. So 120 minutes following the injection and 180 minutes injection shows a good shows the increased uptake in the out area, which you are seeing it, because it clears from the myocardium or it clears from the circulation. So Fdg imaging, therefore, quantifying the vulnerable plaque in a smaller coronary remains a challenge because of the spatial resolution in Fdg limited to only 6 mm with significant Fdg uptake in the myocardium, which I have told you. Significant cardiac and respiratory motion then further degrade the PET signaling using F18 Fdg. So what is the next alternative? 18F sodium chloride has been used as a bone tracer, which I have already told you, detects bone metastasis for many decades, but it has now found potential application in hybrid cardiac imaging. So by exchanging how it acts, fluoride ions with hydroxyl ions in hydroxyapatite crystal. So ligand of F18 sodium chloride hydroxyapatite is key component in early vascular microcalcimia. It binds to the microcalcified area and shows as a hotspot. In a prospective study of a patient with MI, higher F18 sodium chloride uptake was found in culprit plaques compared with non-culprit. This is Dweck et al. He has observed a strong correlation between F18 sodium chloride uptake and coronary calcium score. They have compared. So what he found, 40% of the participants with increased calcium score more than 1,000 had normal uptake. Thereby, one can differentiate biological active plaques from stable atheromatous plaque by CT calcium score. So acquisition protocol, I will not go into that, and all preparations and everything, that is not the thing. Here I can show you that this is a sodium chloride image. We started with the big arteries. So big arteries, here you can see the thoracic aorta and also the myocardium is showing hotspot area. It has detected the microcalcium and atheromatous hot plaque in showing that. Then this is another patient of a 48 years old man with a history of long-standing rheumatoid arthritis. Here is a very interesting. The first set of row where you are seeing the arrow is showing the sodium fluoride uptake value. But in the next row of images, CT, there is no calcium at all. There is no calcium at all. But when you fuse the image with CT, then you can get a beautiful atheromatous plaque using sodium fluoride. And here also in angiography, here also we can fuse the image. There's a lesion in LAD and there is atheromatous plaque in the proximal. Then comes the gallium-68 dotactate. This, as you know, target the somatostatin receptor in surface of activated pro-inflammatory macrophage. These somatostatin receptors are also expressed on activated macrophages and act as a target to the tracer. So it has been demonstrated that somatostatin receptor in M1 macrophages and damaged endothelial cells with atheromatous plaque showing improved description of culprit and high-risk plaques. Then comes the C11 PK119 tracer, then gallium-68 NOTA, RGD, and galacto-RGD. So you know that in plaque neoangiogenesis is a key feature of vulnerable atheromatous plaque. So this gallium-68 NOTA tags with that neoangiogenesis and can be shown as a hot atheromatous plaque. Then this is, I have told you, this is the FMCH for the fluoromethylcholine radioisotope. Then I will show you only one slide, case 3. Yeah, this is a 45-year-old man. I will take 10 seconds only. 45-year-old man presented with chest pain, elevated troponin, F18 sodium fluoride PET-CT performed within 3 hours from the presentation shows increased focal tracer uptake, SU value of 1.7 in the culprit plaque in short axis coronal and sagittal fuse image in the proximal LAD. Subsequent angiography revealed proximal plaque where the patient underwent PCI to the proximal and mid LAD. So here you can see the first row image showing the atheromatous plaque in the LAD area, which you can see beautifully in the left-hand side, and in the CT wise also you can see the images. So this is a good correlation. So limitation of CTA, an event-prone plaque with features of low attenuation and spotty microcalcification has a high risk of progression. CTCA identifies these features but is associated with certain limitations. What? Like slice thickness, variation in contrast opacification. CTCA techniques should be performed such as breath holding to avoid artifacts. So if you combine with F18 sodium fluoride with CT, that is called PET-CT, PET may lead the identification of these high-risk plaques more thoroughly, more efficiently in multiple vessels in single setting. Concluding, nuclear cardiac procedures are no doubt the state-of-the-art procedure in the present-day clinical practice, diagnosis, prognosis, guidance therapy. The field of cardiovascular atherosclerosis imaging is expanding with increasing availability of non-invasive tools of PET, SPECT, CT, and CMR. PET has emerged as a predominant non-invasive imaging tool for characterizing arterial inflammation and guiding the proper treatment planning to reduce vascular inflammation. It can provide important prognostic information related to vascular barrier. Hybrid imaging like PET-CT, PET-MR. So they are the future things which will come. And further, F18 sodium fluoride is the choice of molecule uptake value in magnitude can be used as a criterion to differentiate between culprit and non-culprit plaques in MI patient, useful in cases of multi or double or single vessel disease. Thank you very much for the patient here. Thank you.